So over to you. Thank you.
So firstly, just to thank people for getting in touch, because this is something that's really challenged me. It challenges me as a pediatrician, and it challenged me as an immune deficiency doctor, and it challenges me as an infection doctor to kind of know if I'm doing the right thing. But I think what all of us want to do is the right thing for our patients. And, immune deficiency was part of the original phenotype when this condition was described. And you're quite, some of these children do have 22q11, some of them, don't have that gene defect. But it's also thinking about the timing of this. And I can remember as a registrar in Glasgow in the 90s and this new genetic condition they'd identified. So in terms of old people with DiGeorge, we don't have lots of old people with DiGeorge because we didn't know about it. So the kind of long-term adult effects, I don't know that we're really sure about. With my pediatrician head on, though, to this Japanese article that other people may have referenced, it's parents with children of 22q experience distress, not only due to distress, the multi-morbidity, but also due to professionals' lack of understanding about the condition and insufficient support systems. And that's kind of what I also see in another thing, I don't know, I feel quite passionate about, is children with neurodisability and immune deficiency. And I think it's those same kind of themes. And I think if we can get it right for DiGeorge, we can probably get it right for other children who've got neurodisability and immune deficiency. And DiGeorge is so much more than immune deficiency, heart disease, and hypocalcemia. I'm going to try and run through the role of the thymus in immune function, a bit about a spectrum of the immune deficiency seen, some of the treatment options, the current baseline immune test recommended, which is a little bit woolly almost, and I know I'm woolly in what I do sometimes, a bit about immunization, some interesting things about long-term immune function and what the role of immunology services might be. I'm going to start off with a story about an infant that some people on the call might know, in fact. So term infant, no antenatal problems, readmitted day 5 with 13% weight loss. She was hypernatremic. Nobody happened to check her calcium, but that happens with hypernatremic breastfed babies. She was discharged home, mixed breast and bottle feeding, vomiting consistent with reflux, but there was definitely feed coming back through her nose. And mum thought at birth she didn't look quite like her other children. She had slightly funny ears. 5 weeks old, she developed a skin rash and saw the GP. And the GP clearly looked at that and thought, this is not normal. Was it heat rash? Was it even chicken pox, eczema? They weren't unwell, but had an urgent referral to dermatology. And mum beautifully described seeing 5 or 6 doctors looking at her coming back and then being told this was eczema. 6 weeks old, they go to their caravan on the east coast of Yorkshire East Coast. And she starts having funny eye movements. She then went on to have a prolonged seizure, had a 45-minute ambulance trip to the nearest hospital, a difficult intubation because of hypocalcemia, was transferred to intensive care, continued with the skin rash, slightly reduced lymphocyte count, and then the clever people in the intensive care unit that she was at thought, oh, does this child have immune deficiency? She'd only slightly reduced T cell numbers, but had reduced what we call naive T cells, and I'll go through that. And she had a 22q11 deletion identified, had a normal heart. And I'll tell you what happened to that girl a little bit later on. So a little bit about what T cells do. I know this is really basic immune stuff, so excuse me for the basics, but they've got a key role in your immune system. They'll activate macrophages to kill phagocytosis microbes. They'll kill cells infected with microbes or viruses. But importantly, from a DiGeorge point of view, they stimulate B cells to make good antibodies. So that's why some children with DiGeorge will have an antibody problem despite the problem they're having being a T cell rather than a B cell problem. And similarly, T cells are important in controlling autoimmunity. And hence, if your T cells aren't working properly, as they might not do in some children with DiGeorge, you might have autoimmune problems. They're also important in killing malignant cells. And there's not much of a signal yet about, and other people in the call may know this, about increased risk of malignancy in the long term. There certainly are reported cases of malignancy in children with DiGeorge, but that may be something that comes out the longer we follow these families up. So why do children with DiGeorge get T cell problems? Well, your thymus is an essential bit of your T cell maturation. So most of the children we see with T cell problems are to do with the development of your T cells, sometimes in your bone marrow. But your thymus is where your T cells go to learn what to do. And I don't know if you can see that the arrow here, but your thymocytes come from the bone marrow, and they're not expressing CD4 or CD8 or T cell receptors. They come into the thymus, and that stimulates your T cells to produce, in fact, both a CD4 and a CD8 receptor and your T cell receptor. And as part of the genetic process to produce kind of lots of individual T cell receptors, you get this what's called VDJ gene rearrangement in your T cell receptor gene that results in a T cell receptor that gives you an individual T cell that will see an individual peptide. But a part of this comes a kind of DNA debris byproduct called TREX, and we'll come to the TREX in a second. So you've got this so-called double positive T cell that then interacts with your thymic epithelial cells. And here, for T cells to work, they need to recognize you, and they need to recognize you so that your cells, so that it can interact with your cells that are presenting antigen, and it can also recognize your cells that are infected with virus or are malignant. And any T cells that don't recognize self on the thymic epithelium will automatically apoptose. Through the maturation process, the T cells then have to decide if they want to be CD4 or CD8 cells, and it's more complex than that. The CD4 and the CD8 cells are divided into other complicated types of CD4 and CD8 cells, but there's another kind of negative selection process that goes on there. So we need our T cells to recognize us, but not recognize us so well that we want to harm our own cells. So cells that recognize self very strongly are then auto-deleted. And that's one of the pathways that certainly can go wrong with if you've not got an adequately working thymus, in that you don't select good cells to do things, and you don't unselect bad cells to sorry, somebody's just come into the room. So most infants have very high numbers of what we call naive T cells. So those are T cells ready to go out and find lots of things to do. And your naive T cells are usually greater than 80% of your population of cells if you look at that in a young infant. As we get older, our naive T cells naturally fall for all of us, and we develop more memory T cells. And memory T cells are important too, because they're a function of your immune memory. But what aren't so good are old memory T cells, and these are associated with inflammatory responses and autoimmunity. And we know that children with or people with abnormal thymuses tend to have more old memory T cells and less naive T cells. So TREX are important because TREX are now being used to evaluate severe combined immune deficiency in newborn screening. So as people will know, about 2/3 of the infants born in the UK at the moment, or in England at the moment certainly, will have a newborn screening test done, which will look at their TREX on the dried blood spot, which will identify a subpopulation of infants who may have an immune deficiency, including SCID and including severe DiGeorge. So children who've got low TREX are then sent to an immunology centre. They have blood tests done. We look at their naive T cells. If the naive T cells are less than 10%, that child has SCID or may have complete DiGeorge. It also identifies non-SCID immune deficiency. So those might be infants who've got naive T cells between 10 and 70%, or a total number of lymphocytes less than 1.5%. So the US have been using SCID screening since 2010, and a review of 3 years of their work identified 52 SCIDs, which isn't very many, but it also identified some non-SCID lymphopenias, including DiGeorge and trisomy 21. One of the things to mention about SCID screening is it's the false positivity is much higher than other screening tests, which is partly why there's a pilot being done at the moment rather than just rolling it out. So the UK estimates nationally for what SCID screening will pick up would be about 31 lymphopenic non-SCID children, a proportion of which will be DiGeorges and complete DiGeorges and partial DiGeorges. So there's a number of different immune deficiency phenotypes we see in DiGeorge. We can have children, of most of the kids certainly that I see, who've got normal T cell numbers, but they've often got what you see as a reduced proportion of T cells. So when you look at lymphocyte subsets, you'll see people talking about CD3s, which are your T cells, your CD4s and your CD8s, which should add up to your T cell numbers, your B cells and your NK cells. And usually your CD3 should be about 70% of your total lymphocyte count. And often in the DiGeorge children, you see they've got a normal total number, but their CD3% is maybe about 50 or 60%. Some children have normal T cells but poor vaccine responses. Some children have very low T cells and poor function, but there's probably some children who are maybe completely normal. There's a useful article that a lot of people will have looked at, written by the same people that have religiously come out with the max appeal guidance, but it will report that almost all patients have problems with frequent infections. I suppose that's almost all in the ones that have been identified often in immunology clinics. There will be some that, may not have infections because nobody's known about them. The infections do improve with age, And it's very clear that there are non-immune causes for infections, including the palatal abnormalities, gastroesophageal reflux, swallowing incoordination, which all predispose you to getting chest and ear infections. All children are recommended to have baseline immune investigations, and there's an urgent need for assessment for infants prior to cardiac surgery to identify those who've got severe immune deficiency to see if they need irradiated blood products. There's also a recommendation that patients should be reviewed annually for evidence of autoimmunity cytopenias, including and thyroid disease. So the baseline immune investigations recommended include a blood count and lymphocyte subsets, total immunoglobulins, and then it says lymphocyte proliferation if available. So lymphocyte proliferation or function or mitogen response is a test that we certainly will do in Sheffield. They can do it in Leeds. You wouldn't be able to do it in a DGH easily. It needs at least 5 mils of blood, which is not an easy, it's not an easy thing sometimes to get off a little baby. The results are difficult to interpret, particularly if the child's unwell. It also talks about evaluating primary immunisation responses, and certainly that's what we do in clinic. After we've been referred a child, when they've had their immunisations, we'll see that they've made good responses to tetanus and Hib. And the guidance from that European Journal of Paediatrics says that most children can have MMR, and I think that's true. It also comments about only giving chickenpox vaccine to children if their CD4 count is greater than 200, which is what we would do in HIV positive children. But of course, VZV vaccine is not routinely recommended in the UK at the moment. There's a draft Max Appeal document, again, written by the same group of people that talks about doing lymphocyte proliferation or lymphocyte function if the CD3 total T cells are less than 400, and that's really quite low. Also talks about having non-irradiated blood if the CD3 is greater than 400 and naive T cells are greater than 30%. So it's become much easier for us to do naive T cells. So we can now do naive T cells in the Sheffield laboratory. Up until about 3 years ago, if we wanted to get naive T cells done, we had to send that to Newcastle. And certainly with SCID, it will be easier as well for DGHs to send naive T cells to Leeds or to Sheffield to get done. And again, the Max Appeal guidance talks about being safe to give MMR if the CD4 count is greater than 400 and children have had a normal Hib and tetanus antibodies. So who can get live vaccines? Well, rotavirus is obviously in the primary immunisation schedule, and I think that only needs to be avoided in children who've got SCID or complete DiGeorge, and hopefully those infants will be identified early. In the IDSA and Australian guidance, it says very clearly only to give MMR if the CD4 count is greater than 500 and the CD8 count is greater than 200, and they've had a normal lymphocyte function and they've had normal responses to primary immunisations. Current guidance doesn't talk much about looking at naive T cells, but that might change going forward. For those of us that look at vaccine responses in children with recurrent infections, I think when you're looking at a safety of a child to have or reassurance for a child to have their MMR vaccine, all the guidance talks about Hib and tetanus vaccine rather than looking at pneumococcal vaccine responses. Pneumococcal vaccine responses are a little bit subjective to interpret, but they're certainly useful if you're looking at those children with DiGeorge who do get frequent infections. So another little story. So 6-month-old complex congenital heart disease, normal lymphocyte subsets and immunoglobulins after birth. Our neonatal unit gives us a call. Can they have their vaccinations? So we said, look, do their immunoglobulins, do the lymphocyte subsets. If everything looks all right, yes, they can have routine vaccines because the only live thing in that is rotavirus. And, I think if you've got a sense the child looks relatively normal, that's fine. We see the child at 4 months of age. They haven't had any vaccinations at all. And I think that is this anxiety that sometimes then when the child goes to the GP and they see the health visitor or the practice nurse, and people get mixed up in their head about what's live and what's non-live vaccines. And we're not the only people where that's been the case. This is an article from 2014 from the States. And there was just this sense that almost seeing an immunologist puts a label on you that says this child's immune deficient, and then people don't want to vaccinate you with vaccines that actually are very safe to give. So they had reviewed retrospectively, and this is old data, and they found that 77% of their children with DiGeorge had been given MMR. 58% had completed their immunizations by 35 months. So you can see there's a bit of delay in children getting vaccinated. What they did do then is there's quite a few of them were relatively immune deficient and had been given MMR. And I'm not recommending that people do this, but I think that's what is confusing about the literature. You see that quite often children who look a bit immune deficient can be all right with MMR, but that doesn't mean that they're always all right. And what they also highlighted, there were 14 unimmunized children who suffered vaccine preventable diseases. This is taken from an Australian article from 2020, and I quite like this table actually. So it's suggesting that if you get a baby who's diagnosed as a newborn with a 22q deletion, they have lymphocyte subsets done. you can see here CD3 less than 0.05. This is really, really low. So that's a T cell count of 50. This child has got complete DiGeorge. So, they need that. You're not going to give them any live vaccines, and this child is going to need a thymic transplant. If the count is greater than 50, so it's low, but it's less. It's not extremely. It's not so low. You then go on to do lymphocyte function and look at naive T cells. And if it's between 0.5 and 1, which is low but kind of just below normal, you look at your naive T cells and make a decision. And in the Australian guidance, they're talking about looking at that before they would give rotavirus. I know I've certainly given rotavirus vaccine to children who've not had naive T cells done, but they've got normal immunoglobulins and very normal T cell numbers. But I suspect many of them are in this group, which is the CD4 count greater than 1. And again, it goes through that once you've done that, looking at these children after they've had their first sets of their 2, 3, 4 month vaccines, you can get an idea of their immune function by seeing if they've responded to Hib and tetanus. So why do we worry about live vaccines? Well, it's because of stories like this. So 13-month-old, partial DiGeorge, complex heart disease. People knew this child was immune deficient. They were on Septrin prophylaxis. They had a total T cell count of 396. Low CD4s, low CD8s, and accidentally this child's given MMR and VZV vaccine. And this child died from disseminated disease post MMR and VZV vaccine. Interestingly, they had done lymphocyte function and lymphocyte function was normal. So it's just that bit of rubbish does happen. And then there's another interesting situation here with a child who was 15 months old who developed ADEM 10 days post MMR and consequently was found to have DiGeorge. Nobody knew they had DiGeorge before. Obviously, so it may well be that the DiGeorge phenotype kind of fed into why that child ran into problems. So most children with DiGeorge will be fine with MMR. Many children aren't diagnosed until after 12 months. So often we'll see children they've had their MMR already, but it's still important to think about it. And all children need lymphocyte subsets for T cell numbers and proportions, and we need to be thinking about who needs function and who needs naive T cells. And you've got a bit of time to think before you give your MMR. You've got a whole 12 months to be working out whether you want to give that. So complete DiGeorge, probably less than 1% of cases, behaves like SCID with high mortality from infection in early infancy. There is a risk of graft versus host disease with blood transfusions. The T cells are usually less than 50. Atypical incomplete DiGeorge, which is exactly the case that I presented at the beginning, can have some T cells, and they may be engrafted maternal T cells, or they kind of might be abnormal host T cells that are oligoclonally restricted. So the child I mentioned went on to have a thymus transplant, and thymuses are obtained from the cardiac surgical team. So with consent from the donor parent, thymuses, as I understand it, get in the surgeon's way in terms of managing the cardiac procedure. We like people to leave a little bit of thymus because it's useful to have a thymus, we know, but the thymus is then put into culture and all the donor thymic cells apoptose. So we've just got the thymic structure that's then transplanted into the recipient's thighs. And then miraculously, the bone marrow of the recipient then populates the transplanted thymus. And it's quite an incredible process, given that this is not HLA matched. They blood group match them, but they're non-HLA matched tissues. There is an initial high risk of infection, and these children probably never reach normal T cell numbers. There's an ongoing risk of autoimmunity, and interesting, the similar autoimmunity that children with DiGeorge get with thyroid problems and cytopenias. There's probably 75% survival, which is not as good as SCID with bone marrow transplant. But if you try to bone marrow transplant these children, it's less than 50% survival. Because again, if you think about how key the thymus is, if you give a child a new bone marrow, if they've not got a thymus for the T cells to learn what to do, they're not going to work. And I think now there's about 50 children at Great Ormond Street have transplanted. So that first case had a successful thymic transplant. She went into transplant with severe adenovirus, and in fact, pre and post transplant required prolonged antivirals, and then in fact adenospecific T cells post transplant. We controlled the adenovirus, but she went on to develop significant thyrotoxicosis requiring thyroidectomy. And 2 to 3 years post transplant now, she's got ongoing cytopenias. She's still got low naive T cells, but we're about to try her off immunoglobulin. So in terms of the immunological picture, there's a beautiful article that Andy Jennery did back in 2002 in their immunology clinic. And you can see here a lot of the children that they saw in clinic had infections. A lot of them were on antibiotic prophylaxis, and a lot of them were in fact on immunoglobulin replacement. 2012, this is some joint work between the European and the American Immune Deficiency Societies. Again, this is people who see children in immunology clinics who've kind of referred this to this database. But again, quite a lot of children on immunoglobulin replacement. And a consistent finding is this kind of reduced IgM level. Then in 2019, GOSH produced a really interesting case series. So they looked over 505 patients. I can't remember what time frame it was over, and they, I think, focused mainly on the children that had a total lymphocyte count of less than 1.5, and they've got an age range here of 0.23 up to 30 years of age, and they looked at infection, autoimmunity, and malignancy. Again, 60% of the children had recurrent infections, 15% of them were on antibiotic prophylaxis, and nearly 8% of them had autoimmunity. There's been stuff trying to identify whether children with DiGeorge have more allergies or not, but it depends on which study that you look at. And these are the kind of infections that they got. The one that hit me was this molluscum, and I recently saw a child, again, I think from East Yorkshire, who, to all intents and purposes, DiGeorge immune system wise was all right, probably one of these ones that had slightly low proportions of T cells, but he had horrible molluscum, massive big lesions that I've only seen before in children who were HIV positive. So there was obviously a bit of T cell function issue. From an antibody point of view, the GOSH study showed again this consistent low IgM, but only 2 of the children were on immunoglobulin replacement. But what was clear was that children who got recurrent infections, it was predominantly the palate abnormalities, the reflux, and a little bit of children who had poor pneumococcal antibody responses. So that combination of things tended to make you more likely to get infections. In terms of T cell numbers, what the GOSH team saw was, let me just show you this, was we see over time that we all know that our T cell numbers fall. So if you look at the graph on the right hand side, this red line is normal people up to 20, your T cell numbers are falling. And if you look at the blue line on the bottom, the T cell numbers in children with DiGeorge fall, but they fall less steeply. So by the time you're kind of 15, 16, you've probably got T cell numbers that are similar to other 15, 16-year-olds. But the proportions will still remain a bit off. And as I'll show you in a second, the types of T cells are also different. So in a 16-year-old non-DiGeorge patient with a total T cell count of 2,000, they'll still have a lot more naives than somebody who's got DiGeorge with a similar T cell count. Okay, so how does immune-mediated disease change over time, and can we identify who will get problems? So another child I know quite well, a 14-year-old, complex congenital heart disease. I've followed him since he was a baby, frequent upper respiratory tract infections as a young child, slightly low numbers, but he definitely had a CD4 count of greater than 500. Lymphocyte proliferation was initially abnormal. Was that the test? Was it because he was sick? And then we repeated it was normal. He had all his immunizations, including MMR. He did have one intensive care admission and had PCP positive PCR on a BAL, and we did wonder at the time, is that real or not? Anyway, he's now been infection free. I see him in clinic, and mum's biggest concerns were the long-term impact of his cardiac disease, negotiating and understanding education and personal care support, COVID, to shield or not to shield, and would he have long-term immune problems? And those are the situations it wonders whether, do I need to continue to see this family, or am I perpetuating an immune concern? Is he at risk of further immune problems? But I also think having specialists who know about DiGeorge probably does help these families, because you can be there to kind of listen and understand, and I think that's probably helpful. Quick thing about COVID, many children initially asked to shield, but that may not have been necessary. There is no evidence that children with DiGeorge are at significantly increased risk, unless, of course, they're in that severe complete DiGeorge end. No reason for children with COVID DiGeorge not to have COVID vaccine. I think in adults it's a little bit more difficult. And again, we know that if you look at the adults with COVID, having features of thymic malfunction makes you at more risk of severe disease. And there's certainly adults with complex congenital heart disease and DiGeorge who've run into problems, although clearly complex congenital heart disease itself doesn't seem to be an independent risk factor. So immune-mediated diseases over time. A recent article that Kathleen Sullivan did, again from the States, they looked at over 1,500 patients over a long time frame. And again, similar to the GOSH stuff, thyroid disease, JIA, ITP, they're not big numbers, but they're bigger than you'd expect for the normal population. And they found that thyroid disease was associated with people who had a lower T cell count, and ITP was associated with people who had the lower naive T cells. And lower naive T cells, you're going to have higher kind of memory T cells. This is from the GOSH data, so again showing you the similar picture of autoimmune features, and they had certainly one child who had an EBV-driven lymphoma. A little bit about thinking about, again, why DiGeorge you might get autoimmunity. So we've got what stops us getting autoimmune problems is the central tolerance that I discussed earlier on. So you should get rid of T cells that are going to attack you in the thymus, and if your thymus isn't working properly, may not work properly. Your thymus also has to produce regulatory T cells, and DiGeorge, if your thymus isn't working, you won't produce good regulatory T cells, and the regulatory T cells are a way of kind of peripheral tolerance, kind of getting rid of autoreactive cells, but also this kind of accumulation of kind of old inflammatory memory T cells. Old inflammatory memory T cells is not good for autoimmunity. And this is again a Kathleen Sullivan paper where it's just showing the round circles are the naive T cells in DiGeorge compared to the naive T cells in non-DiGeorge patients, going right up to your 70s here. And similarly, this is from the Great Ormond Street data set. And if you look at the graphs on the right-hand side, the blue line is the DiGeorge patients. And these are the memory T cells through age that are in clearly the memory T cells. The blue line is higher in the DiGeorge group than the red line, which is the control group. I really like this graph, which again is from that European Journal of Pediatrics paper, and it kind of shows immunology kind of here as a straight line. And I had a chat with Andy Jennery last week, because I know that in Newcastle I thought they had a virtual DiGeorge clinic, and I was aware that maybe me continuing to see DiGeorge patients wasn't a good thing, and other people discharged them. But I know Andy does continue to see DiGeorge patients right up to kind of transition age. And maybe what we need with this straight line with immunology is us being very active at the beginning, but then do we intermittently need to get active if they have problems? And then particularly with this transition bit, and now with this, I think it was only 3 or 4 years ago, I was looking at the data and people said, oh, there's nothing to suggest that adults with DiGeorge have any problems. And really over the last few years, there's been increasing information coming out saying, oh, actually, some of them might. And what we need to be looking at is how do we identify the people that might have problems, and either highlight that to adult immunology or at least highlight it to the GP and the family that they might be at risk of this. So I suppose, do all children with DiGeorge need somebody who knows and thinks about their immune system to see them? Certainly at some points in their lives. How long should they remain under immunology follow-up, or should that be intermittent? Are all children getting appropriately immunized? Who should be looking out for the autoimmune features? How are we going to predict who might run into problems as adults? And are there opportunities for us across Yorkshire and Humber to kind of have kind of cross-specialty family-focused collaboration? And I'm going to stop there.
Thank you very much, Fiona.